Hello and welcome. This is a critical appraisal of an article published in 2015 by Dr. Kim and others to look at the risk of VTE from starting new disease-modifying antirheumatic drugs. The researchers asked, how does the risk of VTE differ between different DMARDs, looking at the population of newly diagnosed rheumatoid arthritis patients starting either on a biologic DMARD, methotrexate, or other conventional non-biologics, and the outcome measured was VTE. The only outcome considered was a surrogate marker of discharge from hospital after VTE, not mortality or morbidity. And the only lessons learned was that VTE incidence was low and taking more drugs increases your chances of getting a clot. What they could not establish were what the cause effect were and which drug caused the most side effect. The research question was not answered properly due to bias and design issues, even though the question is clinically important. Ultimately, the results could only be applied to less than 10% of the RA patients. Having 3 exposures and 1 outcome, case control would have been first choice. But is cohort design still appropriate? Let's look at the pros and cons of each design. Case control would be a good choice since exposure to DMARD is common, outcome of VTE is rare, and there are multiple exposures, only 1 outcome. However, a cohort design can compare incidence rates and temporality. Other choices include RCT and prospective cohort designs, which improve the quality of data at the cost of time and money. Therefore, retrospective cohort reaches an acceptable balance. Let's take a closer look at validity. The study addresses a focused, clinically relevant, and clearly identified issue. Data selection was thoroughly presented, but the reason for inclusion and exclusion were not always explained, and it was not clear whether the cohort was representative of the target population. While some criteria were easy to understand, others only restrict generalizability without affecting confounding bias, as listed here. Exposure measurement was objective and clearly defined, but there were missing data for any drug that the insurance did not cover. Most importantly, there was an issue with the grouping of exposures. Patients in the biologic group could also take methotrexate and other non-biologics, so it's not surprising that patients in that group would experience more adverse effects because they're taking more drugs than the non-biologic group. There are better ways of dealing with the overlapping areas on that Venn diagram. The authors could have ignored the overlap regions and only analyzed single drug usage. Or if the sample size is too small for that, allow multiple entry of patients taking more than 1 DMARD. The measurement of outcome was also objective and consistent across cohorts, but by only looking at discharge diagnosis of VTE, there was incomplete collection of outcome data. There are many issues with using a discharge diagnosis. The patients could have come to the hospital for an unrelated issue like bone fracture, then developed a clot, or it could have been from the medical treatment they received while in hospital. There would also be undetected VTEs if patients died outside of the hospital or died during a hospital stay. None of those patients would have a hospital discharge. To give praise where praise is due, a major strength of the article was how comprehensive the list of confounders was in Table 1. Baseline demographics were very consistent across the 3 groups, and the ones that were statistically different were highlighted. Even then, you can see that they were not extremely different. It was difficult to tell if follow-up was long enough because we don't know the pathophysiology of how a DMARD can lead to a clot. Now that we've looked at the biases, let's look at the results. Revisiting the original question, how does the risk of VT differ between DMARDs? Well, the answer was inconclusive, with just a weak signal showing that biologics and non-biologics might have higher risk than methotrexate. The authors tried their best to minimize confounding factors, to compare propensity score matched hazard ratios and incidence rate, but the endpoints were so uncommon, and the differences did not reach statistical significance for most measures. The results were not that precise. Even with a sample size of almost 30,000 patients, the confidence intervals were very wide. The authors concluded that there was a higher risk associated with starting a biologic agent, but didn't mention how most of the results were not statistically significant at all. And worse yet, there was a contradictory result on the next page. By stratifying the time frame, You can see that in the first 180 days, there was a higher risk of VTE in the biologic group versus the non-biologics. But look down a little bit more. After 730 days, what is this, a protective effect of using biologics? This was not mentioned in the conclusions. Who can we apply these findings to? Since only 10.8% of rheumatoid arthritis patients were included in the analysis, and that's talking about people with private insurance, it means we can only generalize these data to less than 10% of rheumatoid arthritis patients that we see. If the bigger circle represented the PICO population, then the small circle is all that we have left after the inclusion and exclusion criteria. The take-home message from the study was that the evidence was not enough to recommend either stopping a DMARD or starting an anticoagulant. But maybe if somebody is started on infliximab, we might pay more close attention to their clotting factors. In conclusion, the study generates a hypothesis that maybe some biologic agents can increase the risk of VTE, but we cannot really apply this result to the majority of our patients with rheumatoid arthritis, and no recommendations can be made at this moment. Thank you for watching this presentation.